So I have to say it's a little like Back to the Future here for a couple of reasons. One, because we're still dealing with a lot of the issues that are being discussed today, for better or for worse. So I'm sorry to say that this is not all solved in Massachusetts. And in fact, with implementation of the Affordable Care Act, while it was modeled on what we did in Massachusetts, which by the way, we never called Romney Care until there was Obamacare, then people started calling it Romney Care. So we call it Chapter 58 by the bill, the name of the law. But anyway, so we're still dealing with a lot of the issues, and when we were trying to implement the Affordable Care Act, we had a lot of bumps in the road as well, and we can really, what you're dealing with, it resonates with us, especially with the technical difficulties. We had a lot of problems, and so in some ways we feel like we're starting over again. And so we feel like we have to re-tackle a lot of these issues, and there are some lingering issues that we still haven't gotten to, that small percentage of people who are uninsured and how to reach them, for instance. So I wanted to talk about a few things, but I won't go through too much. I have kind of all these talking points that I'm not going to be able to get through, but I'd be happy to talk to people offline. One is enrollment is always going to be an issue. So trying to get people, as Lena said, into the correct plan is always going to be confusing for folks, especially when they're transitioning from different coverage. So say you're transitioning from Medicaid to the exchange, or you're transitioning from employer-sponsored insurance, and you've had employer-sponsored insurance your whole working career, your whole adult life, and all of a sudden you lose your job and you're in this realm of health insurance that doesn't make any sense and is super confusing and that you've never really had to deal with before because your employer took care of it. So there's always going to be enrollment issues to deal with. And one of the ways we've made it easier, and this also goes to affordability, for our folks under 300% of the federal poverty level, that's about $35,000 a year for an individual, we have a program called Connector Care. It's modeled after our waiver program that was in place before the Affordable Care Act that covered people with subsidies for premiums and cost sharing up to 3 times the poverty level. So we're very lucky for that population. They don't have any deductibles or coinsurance. It's really affordable premiums, so we kind of supplement, and I think Lydia, you might be talking about more of the affordability piece, but we supplement the APTCs and cost sharing reductions for people in these income categories so that the premiums are more affordable and they just have to worry about co-pays. And there's only a subset of plans that are offered to those folks as well. So I don't know if that's something that's viable in Maryland, but I'm happy to talk more about that program as well as a way that we've kind of been able to keep our legacy program and also keep it a little more understandable for that population. But with the ACA, there are additional subsidies that are available to the 300 to 400% of FPL population that didn't have that available before, so that was a big boon to folks. But even though we've had an exchange since 2006, 2007, people still are struggling with how to navigate the system. They're still struggling with how to choose a plan that includes their providers, and that there's a lot of talk about network adequacy. One of the things about health insurance is that these contracts between insurers and providers are always changing. So even though your provider might be in the network now, there could be some change down the line that changes that. And I'm sure here, and there's other continuity of coverage sort of regulations and things that help out with that. But in the long term, it's really difficult for people to keep track of all of that. Access to providers to begin with, as in we see a lot of people still who choose a plan that does not include their primary care physician or does not include the specialist that they need to see. And they only find that out when they go to seek services. And we do have some special rules for people under 300. Well, actually, we did have some special rules in our previous program that people could switch, but now they can't unless you're in Medicaid. So that's kind of a big barrier. Also, we have regional disparities, geographic disparities within the state with regards to access to providers for people in public health insurance programs in particular, but even people who are not getting assistance and who are have private health insurance. So there are certain regions and areas of the state where it's difficult to even find a primary care physician or a specialist. And we do pretty well in Massachusetts with that, with regards to the number of residents per physician, and with regards to having a lot of providers in the state. So I can only imagine what it is for a lot of other states dealing with that. The other piece I just wanted to talk about was renewal and re-enrollment, and the fact that people have to annually recertify that they're eligible for programs, and that may transition to other, from say Medicaid to the exchange. And one of the things that we've seen is that when people transition, they're not used to having to, because in our Medicaid program we'll have auto assignment to an MCO, for instance, but once you get to the exchange, you have to make that step to enroll in a plan. Otherwise, you're still uninsured. And people still have trouble with that concept. They think they're all set once they get the eligibility determination. And in fact, we've had a problem this past year, which a sentence fell off the notice somehow, saying, okay, congratulations, you're eligible. Your next step is to actually enroll in a plan. And so people just kind of sat there eligible but unenrolled. So there are still a lot of issues that we're dealing with, and I'm sad to say these are not all solved. So I feel you when we're talking about all this, and I'd like to hear from you. There seems to be some great ideas floating around in this room as well, and we'd really like to learn from you in Massachusetts as well. So I'm sorry if I took up too much time.
No, that was fantastic. I'm actually just going to ask you to elaborate a little bit on what are some of the strategies and other things that you use to help consumers. So like Lena was talking about, are you employing some of the same things in Massachusetts to really help consumers know that they need to further enroll, to make sure that they're choosing a plan that meets their needs?
Yeah, so we're very lucky at the organization I work for, Healthcare for All Massachusetts. I work on the policy team, but we also have a direct service helpline, which I'll talk about a little more this afternoon as well. And we directly help people navigate the health insurance system, help them through the application process and the plan selection process, and even further beyond that to get access to services. And we do have a really good history of enrollment assisters in the community. Almost all our hospitals and health centers have certified application counselors that can help people through the process. We also have a partner organization called Health Law Advocates that can help people with, service denials and appeals and things like that. So one of the things that's really important, and I think that this was discussed before and brought up before, is just kind of hitting people multiple times. You can't just talk to them once and feel like they're all set. There's consistent follow-up that's needed. Some of the tools that we use is our helpline clients can sign up to get text messages for the month that they're supposed to be. Our renewals got messed up the past couple of years because of the system delays, but get text messages for the month that their renewal is supposed to happen, so they're aware of when it's coming up and that they should call us if they need assistance with the renewal. We've done a lot with, at our organization in particular, local and ethnic media. So we did talk about the fact that media in and of itself is not the end-all be-all, but there is really something to be said on getting that on that local radio show that caters to Spanish speakers in that area or Portuguese speakers in we have a lot of Portuguese-speaking folks in Massachusetts. So those are some of kind of the strategies that we've dealt with, and just at the beginning, really honing in with people that you need to. What's most important to you? Is it most important that your provider is in the network? Is it most important that the premium's low? And kind of walking through what the most important things are to that person and help them through that process.
Thank you. So I want to shift a little bit to Lydia and talk more about what some of the carriers are actually doing to look at different design options, or what are some states looking at to have some kind of innovation so that plans do become more affordable and can better meet the needs of the consumers, rather than, as Carolyn was mentioning, our exchange has 60 plans offered. They all provide the EHB. They all have, similar networks. What are some of the differences there? So, what are carriers doing in regards to plan design? What are you seeing across the country about carriers changing plans to better meet affordability standards?
Yeah, I do think that there is growing recognition, kind of a groundswell among regulators and among carriers, that out-of-pocket costs are a problem for consumers. Consumers are becoming more aware of it. Deductibles are too high, and if we're going to make coverage actually translate to care, we need to be doing something different for this population. Carriers and regulators are looking at a number of different options. I think one of the most common strategies we're seeing more plans come onto the marketplace that do cover certain things pre-deductible. So doctor's visits, generic prescription drugs, you only have to pay a copay for those. And some carriers are just doing that voluntarily, recognizing that it's probably in the best interest of keeping their enrollees out of the ER. Some states are taking a more active role in making sure that these are in their exchanges. And a number of state exchanges have designed standardized plan offerings that incorporate these elements into them, and that every single insurer is required to sell on their marketplace. And so in those states, consumers know that they can buy a plan from any single issuer that covers a number of outpatient services pre-deductible. Moving towards some newer strategies, carriers are looking at something called value-based insurance design, which is where insurers price the cost sharing for a service based on the clinical value of that. And so, for example, I think a really common element that insurers bring into their plan design is for people with chronic conditions like diabetes, like asthma, like hypertension. Just for that patient population, we're going to reduce or waive cost sharing altogether for those medications, for those trips to the doctor's office that the insurer knows is really important to them, being able to properly manage their condition. And I think there's a lot of potential there, and I think we'd like to see more carriers look at that option, but it does need to be implemented carefully. And value-based insurance design can also be brought into networks. So an insurer might have a multi-tier provider network and say, well, the first tier of this provider network, they're considered high-value providers, and we will reduce cost sharing if you go see them. And again, I think that does need to be implemented carefully. We're already dealing with a lot of network adequacy requirements. And then the third strategy I wanted to touch on that a lot of insurers, I think, raise as a way to help with affordability is wellness programs. And they have traditionally been in the employer market, but I think we're going to see more of them come in to the individual insurance market. And they can be a lot of different things, but I think the programs that consumer advocates most need to be aware of and understand are the ones that vary cost sharing for a consumer based on them meeting certain requirements. So a wellness program might say, well, if you complete this online health risk assessment, or if you complete this telephonic health coaching, we'll reduce your deductible or we'll reduce your copays. And on their face, they can look like a strategy to address affordability and improve it, but with those, the devil's really in the details about whether the opportunity to obtain that reduced cost sharing is truly available to every consumer, and whether what the health plan is asking them to do is really feasible. So I think that's kind of a overview of what we're seeing.
So, I mean, we're talking about complicated insurance designs, and talking about, you know, what do we need to make sure are included in those plans or not included in those plans. Can you maybe elaborate a little bit more on, as advocates and as consumers, and navigators, what do we need to make sure that consumers understand about the value-based insurance design plans as well as the wellness plans, and maybe what do we need to make sure that we're getting from the carriers to make sure that consumers are understanding what they're protected from and what they need to be worried about or concerned of?
Yeah, so in the world of value-based insurance design, I think an important thing to keep in mind is that there's a really good side of it where you can have reduced cost sharing for really important services. Insurers might bring in another element where they're going to say, there are some services that we consider to be low value, and we're going to increase cost sharing for them. The theory being, we're going to indicate to the consumer that this service isn't necessary for you, and a price trigger should indicate to you, well, I shouldn't get it. You know, in theory, you know, there is some value in that because there are some services that are harmful or are not cost effective, and it would be nice to steer patients to that. But in practice, the reality is consumers aren't really in charge of those types of healthcare decisions. Their provider is, and so you have to be really weary of treading into this territory of charging more for lower value care in the current healthcare climate that we are in, where providers are really the ones left being in charge of that. And I think until we get providers to start making better treatment decisions, we can't have consumers left holding the buck on that.
Yeah, I mean, I think that's a really good point, and I think Lenny's going to talk a little bit more about that in a panel later today about consumers actually needing to be a more participatory member of their treatment team, because until they are, then allowing them to, or forcing higher costs on things that they are not necessarily the decision maker about, or don't feel empowered enough to be the decision maker about, is really concerning, I think.
Yeah, and the other things I'll mention on the VBID and wellness front is, because network adequacy is such a concern, I think when you're looking at plans introducing value-based insurance design networks into their plan and having tiered networks, you want to make sure that that first tier of providers, those high-value providers, are, one, truly high value, that they're providing high-quality care, they're not just providing low-cost care, and also that that's an adequate network of providers so that consumers can actually go see a high-value provider and take advantage of that reduced cost sharing And then on the wellness side, I think the really important thing to look at is what are the requirements and are they really fair to a consumer, and are they why would a consumer need to do them? So health risk assessments that are online. Well, if a consumer doesn't have ready access to the internet, accessing that reduced cost sharing might be illusory to them. And on top of that, there's not a strong evidence base to show that health risk assessments can help improve people's health, and so it's kind of, you're asking them to jump through hoops to get the benefit that they need. And the last thing I would be wary of is sometimes we see value-based insurance design and wellness incentives kind of merged together. So a plan will say, we have this value-based insurance design program where if you have a chronic condition, you can get reduced or no cost sharing for your medications. But to do that, you need to participate in our disease management program. Well, if that disease management program isn't really accessible to their enrollees, then where value-based insurance design is all about reducing financial barriers, you might just be creating another barrier to them accessing that service and that benefit. So I would be cautious about when people bring wellness into value-based insurance design. They're very different, and I think that wellness can handicap value-based insurance design success.
So we are, we were earlier talking about just trying to help people choose based on the current plan design, right? So now we're going to complicate that by adding value-based, we may complicate that by adding value-based insurance design plans and wellness plans onto the mix. And so my question for each of you is, you can just take it as, go down the line, take it as you want, is what do you need in your role, or what do you see as consumers really needing from the carriers? So what is missing from what navigators have or from what consumers have themselves that they need in order to actually make good decisions about the current plans as well as some of these more complicated plans?
Can I start? So as you were speaking, Lydia, I was thinking that one thing that is really helpful for connector entities and navigators is to really get more information about plans. So I don't know if this is universal, but most navigators, at least at HCAM, don't come to this job with a health insurance background. They come more with a case management background or an interest in helping people. They don't have a lot of experience with these products. So the tools that they have to assist consumers in selecting a plan are really the SBC, the Summary of Benefits and Coverage for the plan, which is standardized and easy to read, but doesn't always have all of the information. And a lot of times it's really difficult for consumers to get information about a plan before they sign up. So someone will really want to know, well, I have diabetes. How much will it cost me for this treatment? And sometimes we hear from the carrier, well, until you sign up, we can't tell you that. And so we really need more, as advocates for consumers and as the front line of people who are helping consumers, we really need more information about the plans. We need to know what differentiates one plan from another plan. We need to be able to have that information to help consumers really make the best decision for them. Not so that we can steer them in one way or the other, but as they're comparing plans and saying, well, what's the difference between this Kaiser Permanente Silver plan and this Evergreen Silver plan? Our staff needs to be able to fully understand that themselves so that they can explain it to a consumer. Because I don't think that it's good enough to just say to someone, well, take a chance, sign up for it, see how it works for you. If it doesn't work, you can come back next year and pick something else. They're spending their hard-earned money on a plan, and we want it to work for them, because if it doesn't, they're going to come back to us to find out what their options are, and if it's after open enrollment, their options are really limited. So we want to be better equipped to help them on the front end.
I can take it. So I echo you, and we do a lot of analysis of plan documents to try to figure out what's going on ourselves, and I can't imagine how infuriating it is for a consumer because we're looking at it and we don't know what's going on. I think more accurate information is key. I think as we tread into this world of more complex benefit designs that do have a lot of potential to improve access to care for consumers, but are adding a new layer of confusion to how their benefits work, you need a tandem effort of how do we communicate these new designs to consumers, how do we educate them about their value-based insurance design benefits, so if they do have a chronic condition and they have this great access to no cost sharing for their diabetes management. They actually know about it. I also think with these newer types of benefit designs, there's also a lot of additional protections that need to come into place with it. When you're talking about a wellness program, should people have an alternative way of, meeting a requirement if, say, they can't complete an online health risk assessment, and making sure that not only is that right there, but that the plan is very clearly advertising that right to consumers and the number that they can call to get help, to get an alternative way to obtain that incentive in value-based insurance design if they have a value-based network and they can't find a provider in the first tier high-value network. They should have a right to go to the next network and not pay additional cost sharing. Well, who do they call? So I think there's enough added education in their rights in these new programs as well.
I'm just going to add really quickly, we are one of the states that has standardized benefit designs, which has been really advantageous for consumers to actually compare apples to apples, because within this, this specific silver standardized benefit design, the only thing that's different is the premium in the network. So that's easy to help people with. So that's been very advantageous for us. What we're trying to do is we're having more plans that are not standardized coming in, and then also if any of these value-based insurance designs or things with wellness incentives come in, is to at least be able to sort of flag them some way and have some sort of pop-up to identify, like, this is a little different than what you might be used to, or this is something you might want to look into depending on what your current needs are. The other thing I forgot to mention earlier on the affordability side, and these are just like little website things that we've been working on, so I just wanted to mention them, is around the high cost sharing piece. For the next open enrollment period coming up, our exchange is going to implement a pop-up after someone submits that they choose either a bronze or a catastrophic plan, a pop-up warning about the high cost sharing in those plans to say, are you sure that you want to buy this plan, and this is what this deductible means and all that sort of stuff. So I just wanted to bring that up too, because I was just thinking about that, of what are these little tweaks that we can make that at every chance we get to kind of educate people.
That's great. Those are the types of things we need to hear from Massachusetts that we could maybe push for. So I'm cognizant of time, and so I want to see if there's any questions in the crowd. I mean, I can keep asking these ladies questions, but I want to see if there. Can someone go ahead and stand up and see if we can hear you? I'll repeat.
Thank you. My name is Mike Shaw. I'm with Calvert Healthcare Solutions, and we oversee the Connector program in Southern Maryland. I don't know if there's a question in this, but it's just a point that we were talking about the enrollment numbers earlier and demonstrating how much enrollment over the past year that we've had within the Medicaid program within the state. And what we're also finding is moving forwards that how many of those people, when they're having an eligibility determination done, are actually eligible for a QHP versus the Medicaid that they were previously enrolled in. Two completely different animals, because with Medicaid, in terms of services, you're relying on what the MCOs offer and if there's any differences between the MCOs, but they're pretty straightforward in terms of that program. However, once they become eligible for a QHP, there's this whole window of opportunity and decisions that have to be made. So I think maybe from a top level kind of thing, what we can look at moving forward, is there ways that we can tie in how the MCO program works within Medicaid, as well as the program through the commercial products, and so that we can kind of engage those consumers a little bit more effectively. And, especially if there's that going back and forth thing. So I don't know if, like I said, I don't know if there's a question there. It's more of a comment, but I don't know what the numbers are in terms of people that came out of Medicaid into a QHP. But, we're at least within our region, we're seeing, a fairly significant number of that occurring. So
that's a fantastic comment, and I'm actually going to turn it into a question. I'm going I'm going to ask Suzanne to talk maybe a little bit more about the WRAP program. I think one of the things you were kind of hinting at is this idea of like a basic health plan. So there's kind of a bridge between the Medicaid program and the QHP program so that there's maybe less fluctuation, which I think is what your WRAP is doing.
Yeah, so this comes from a long history of creating a program back in 2006 called Commonwealth Care, which was our waiver program for people up to 3 times the poverty level. It was a Medicare-like program, however, it was run through the exchange. So we saw it as a Medicare-like program. The exchange and other regulators at the time saw it as a private insurance program, subsidized private insurance program. But so that led to some differences. But that said, at the beginning of the program, the MCOs who were offered coverage through our Medicaid program were also the same MCOs that offered coverage through our Commonwealth Care program. So that helped create this glide path for people who are transitioning between the two programs. With our current Connector Care program, which this name is very similar to Commonwealth Care, our QHP WRAP program, we have a similar structure. All the MCOs that are offered through Medicaid are now actually, well, some of them were before, but they're all actually licensed insurers through the state. And so now they are able to offer on the exchange and outside the exchange private health insurance plans, but they are also the ones that are the subset of Connector Care plan. So you can only get the additional state subsidies if you purchase a Connector Care plan. So the same MCOs that are offered through our Medicaid program, for the most part, are offered through the Connector Care program, although there's one addition to another plan, our co-op plan that came in under the ACA. So there's one addition, and then there's another addition under our Medicaid program that's not in the exchange. But other than that, they tried to do it so that the plans were very similar. They have experience dealing with these populations that may be transitioning between the different programs, and it's been really helpful for people to stay with the same insurer and keep the same provider over time. So that's kind of what our Connector Care program looks like. The other thing that we've done to ease the transition between Medicaid and the exchange is we are allowing people to stay on their Medicaid coverage to the end of the month before the first of the month of when their QHP starts, so that there is less of a gap in coverage if someone's Medicaid ends the mid-month but you're not enrolled in the QHP till the first of the month. So that's another policy thing that we've done to help ease the transition and avoid some gaps in coverage.
So I'm just going to ask 2 quick follow-up questions. One of you, Suzanne. So how do you pay? How does Massachusetts pay for those state subsidies? Like, is that a general fund allocation? And then I'm going to ask a question of Lydia. Maryland doesn't have. I think the gold standard is to have your MCOs participating in the QHP market so that the plans are similar, so you don't have as much kind of shock moving from the Medicaid market to the private insurance market. We have some, but I think even though we may have some private health plans who have an MCO, I think it's still a very different type of plan. Kind of across the country, is that happening? Are other states seeing their MCOs selling QHPs? So I don't know if you want to answer my budget question.
Sure. So budget, a lot of it is a holdover from how we helped to fund our Commonwealth Care program. So there was an increase to the cigarette tax back in 2008. That the amount of that increase, the dollar increase, goes to the Connector Care program. We also have our own state individual mandate, and we used to have our own state employer mandate, but that was repealed as of July 2014. Any funds we collect from those mandate penalties go to the Connector Care program. And in addition, we used to have a program for people who were uninsured and receiving unemployment assistance. That was a separate program from all the other programs we had, in which employers had to pay into. And so they reconfigured that so that there's a new employer assessment to pay in to help with the Connector program. So those are the 3 kind of funding mechanisms there.
On the Medicaid managed care, I think it's something we want to look at more in terms of how many are kind of entering the market in every state. I would say anecdotally through our research, kind of looking from a different angle at what are some good plan options out there in the country that we can lift up. Oftentimes they tend to be run by Medicaid managed care. And I think it's because they're used to working with the lower income population, they're trying to grab those people who are moving from Medicaid to private insurance, and so they are tending to design their plans in a more nuanced way with more pre-deductible coverage for a lot of outpatient services. So I think you know, if there's appetite from a Medicaid managed care to enter the private insurance market, they might be open to, you know, just discussions about how are you thinking about designing your plan? Have you thought about what your cost sharing should be? Here are some ideas we have. I think that's something we think that they might be a good partner in potentially. And I would say, just anecdotally, we also have seen Medicaid managed care actually tend to be more involved in exchanges where there hasn't been Medicaid expansion. So I think those are the two trends we're seeing.
Other questions from the crowd?
Thanks. I'm wondering, I represent Special Olympics athletes, and mobility and access to healthcare is a major issue with us. I was wondering if the panelists could comment on any knowledge they might have from the providers as to how they're looking at the aspects of telehealth and telemedicine.
So this is a tiny little subset, but actually HCAM is just in negotiations with Wexford Health. I know that they oversee the discharge planners for a lot of the Maryland State Detention Centers, and they use telehealth a lot in their health system. And so we're working with them on using their technology to help enroll inmates who are 30 days pre-release into Medicaid. It's basically via a Skype system. So it's in-person assistance for inmates who are currently incarcerated, who are about to be released. It's a very small subset. It's their chronic condition and behavioral health inmates who we know upon release will need immediate connection to care. So either weekly therapy or appointments with a doctor because of their chronic condition they're managing. So we're about to launch that. So that's a very small piece of what you're asking. It's not actually telehealth in terms of treatment, but it's connection to care for a population where a gap in coverage could mean detrimental things for their care.
So I will say that Maryland is, and this is not my area of expertise, but Maryland Medicaid did just publish its telehealth regulations not too long ago, and I know that, again, I speak from the mental health perspective, I know that telepsychiatry is something that is allowed now across the state, and I know that there are some insurers who are using telehealth. I'm not sure exactly what the take-up is on that and how they're publicizing to their members that it's available to them. I mean, I think that's kind of the next step, right? So if you have, say, a Care First is using, telehealth in some of its rural areas, are they making sure that those members know that telehealth is an option to them and making sure that they understand how to use the telehealth? And so I think those are some of the conversations we need to still have with them, that, yes, you put this program in place, but are we actually making sure that people can utilize that program to, especially in the rural areas and especially with specialists who aren't, we know in Maryland, we have a lot of our specialists are in certain areas in the state, right? They're in Baltimore. So making sure that people can use telehealth to access them, but understanding that it's available.
One of the things we're seeing in Medicaid, as well as our private health insurance and the programs that are now in grants and things on Medicare, is the movement to global payment. So we're moving from the fee-for-service to global payment. And that's created in Medicaid, and I'll speak for those in maternity care, a real problem in getting paid for some of the services, particularly those services in preventive care. And one of the big examples when I'm with the obstetricians or nurse midwives or other happens to be breastfeeding, for example. Before, we could always get this little bit of money which would help pay for that staff person for breastfeeding. Because the problem we have, even with our hospitals now, you'll see across the state, oh, you can go for a breastfeeding class, but it's going to cost you over a period of time, it's going to cost you $75 to $100. So have you had a chance yet to look at the movement in Medicaid as we change our billing practices with the MCOs?
I mean, I can speak a little bit from the national perspective. I wish I had some of my colleagues here to channel some of their brilliant expertise. I think as we move towards global payments with MCOs and the idea of changing the way we pay providers to drive better quality and care, we have to be careful and be cognizant that just changing the way we pay an entity isn't going to change how they use that money. I think people think we give an MCO or an ACO this big chunk of change and say, you have all of this power now to do all of the things you've said you wanted to do, but fee-for-service wouldn't pay you. Well, on the flip side, are they going to direct those funds in the right way, and who's in control of the global budget, basically the global budget's budget? And so we're kind of getting outside of my depths. I'm happy to talk more with you later about my colleagues, and Nick could put you in touch with them. But I do think there does need to be some thinking about global budgets aren't just this panacea that's going to solve everything. There's some further discussion that needs to happen.
And there is a panel coming up later on this afternoon to talk a little bit more about global budgeting as it relates to the hospitals. And I would also suggest that one of the things Shannon brought up was this new ACO that they're looking at for the dual eligibles for Medicaid, so people that are dually eligible for Medicare and Medicaid. And I would suggest that if folks have comments or concerns, to actively participate in that planning process, right? Because that's what we want to make sure, that the people who are on the ground, the consumers, are actually getting their voices heard as these grandiose new programs are designed. We want to make sure that things like exactly what you're saying aren't kind of left by the wayside. I think we have time for one more question.
Hi, Susan Wood from George Washington University School of Public Health. I just have a question about, well, actually I want to reiterate as a comment the need for more information about the plans. I think everybody who's tried to look at them from whatever perspective to find out what their particular health condition or benefit or whatever is, at the national level all the way down to consumers, is frustrated by the fact that you have no information really about what plans cover. So having that granularity is really important from the plans. The second piece is about actually the wellness programs and other ways to improve people's health through incentives for wellness. And although sort of the big picture, that sounds lovely, I think the concern I have about it creating actual barriers, the specific for Maryland, which I know some of you are familiar with, is that state employees are subject to completing a wellness series of activities, including a visit to a provider and signing off and uploading documents and all sorts of stuff. And if you don't do that, it's not an incentive. It's not that next year you won't get the benefit. It's next year you'll pay more in your premium. And it's actually a penalty if you don't complete the wellness program, which has all sorts of barriers just inherently built into it. So I think we need to watch out for that and figure out ways that it's actually not only actually has health outcome benefits, but it actually not only presents barriers, but they aren't actually charging you more if you don't complete the series.
Yeah, no, and I completely agree. And I think in the individual market, consumers are lucky in the sense that there are certain types of wellness programs that just aren't allowed. And so what you're going to see is much more limited. But I think even in the individual market and the wellness programs I talked about, we need to be very mindful. Like, I don't think they're going anywhere. They're not. They're going to be around for a long time. We're going to have to deal with them. So people need to try to basically do harm reduction on them. And then I think right now in the individual market, we're lucky people can't be charged higher premiums based on completing a wellness program. That's just in federal law. But I think when we are looking at employer coverage, I echo all of your concerns, and I think we need to be kind of watchdogs to make sure it doesn't move into the individual market in the future.
So I just want to thank all of our panelists, and I invite Lenny back up to the stage to hand out these lovely tote bags.